Support team, can we start?
Yes, ma'am, we are live.
Okay. Welcome and good evening, everyone. I would like to invite Dr. Rohit Swami. He is a consultant medical oncologist, Narayana Multi Specialty Hospital, Jaipur.
So, good evening, everyone, and welcome all of you for this interactive session. Today, we'll discuss about the urothelial carcinoma and what are the recent updates in urothelial carcinoma regarding NACT as well as adjuvant therapy as well as role of immunotherapy and targeted therapy in urothelial carcinoma. So we have our speaker, Dr. Mukesh Mandawaria, who is a renowned pulmonologist in Railway Hospital and having a special interest in each and every type of carcinoma, especially urothelial carcinoma. And he will enlighten us about the basics and detailed knowledge about the urothelial carcinoma. So, Dr. Mukesh, please.
Okay, good evening, everyone, and thank you, Dr. Rohit, for introducing me. Today, we will discuss about urothelial cancer or urinary bladder cancer or transitional cell carcinoma. Next, I will just give you overview of bladder cancer, and which include epidemiology, types of bladder cancer, risk factors, clinical presentation, staging, diagnostic modalities, management modalities, and prognosis. Next. Now we come to epidemiology. The bladder cancer is the 10th most common cancer, accounting for 3% of all cancer cases diagnosed worldwide. And it is the 6th most common in men, accounting for 4.4% of total new cases. Estimated approx 4,41,000 new cases of bladder cancer worldwide. And this is the incidence rate per sex among 10 top cancers. And the incidence rate of breast cancer is very, very high, and followed by lung cancer, colorectal cancer, prostate, stomach cancer, liver cancer, cervix, thyroid, esophagus, and bladder cancer at the 10th position. Next. And this slide showing the incidence of bladder cancer statistics in India as per Globocan 2020. And it's showing the incidence rate and death rates are very high in the bladder cancer. Next. And this is the trend in age adjusted incidence rate of bladder cancer in India and Tata Memorial Hospital. And the incidence rate in males is very, very high as compared to female for the bladder cancer. Next. The types of bladder cancer. There are mainly 3 types of bladder cancer: transitional carcinoma, squamous cell carcinoma, and adenocarcinoma. The transitional cell carcinoma is the most common cancer for bladder, that accounts for about 90% of all bladder cancers, and followed by squamous cell carcinoma, which accounts for about 4%, and adenocarcinoma, this accounts for the about 3% of all bladder cancers. Next. And there are the risk factors associated with the bladder cancers, and smoking is the most important risk factor for development of bladder cancer. Bladder cancer is more than 3 times more common in smokers. And other risk factors are the male, Caucasian race, and age more than 55 years, genetics, personal history, having urothelial cancer, other urothelial cancers, or chronic bladder irritation and other infections, and exposure to certain chemicals like benzodine, beta-nephthalamine, certain medicines like pioglitazone, the prior history of chemotherapy or radiotherapy, and low fluid intake. Some herbal supplements containing aristolochic acid are also risk factor for the development of bladder cancer. Next. Some occupations are at high risk for development of bladder cancers because they are using aromatic compounds, and these occupations are dry cleaners, painters, auto workers, truck drivers, paper manufacturers, metal workers, plumbers, hairdressers, tire and rubber workers, chemical workers, and petroleum workers. Next. This table is showing the sign and symptoms of the bladder cancers. The hematuria is the most common symptom of bladder cancer, and hematuria may be gross hematuria or maybe microscopic. And patient may have some irritative symptoms like dysuria, frequency, nocturia, urge incontinence, or urgency. Patient may present with complaints obstructive symptoms like decreased force of stream, feeling of incomplete voiding, intermittent stream, or straining. Patient may have some signs and symptoms of metastasis or advanced disease like abdominal pain, pelvic pain, and patient may have some constitutional symptoms like anorexia, weight loss, or others. Next. Staging of bladder cancer. We call stage 1 when the tumor confined to the internal lining of the bladder. In stage 2, the cancer has spread to the muscle wall of the bladder. Stage 3, the cancer has already grown to the fatty tissue outside the bladder vessel. And in stage 4, the cancer has metastasized from the bladder to the lymph node or other organs or bones. Next. We can divide bladder tumors in on the basis of invasiveness. The non-muscle invasive cancers, the tumor is confined to the superficial layer of the cells, are non-muscle invasive cancers. If the cancers have grown to the deeper layer of bladder wall, are also known as muscle invasive cancers, or stage 2 and 3, and these are treated by surgery or radiation with the chemotherapy. And the metastatic bladder cancer or stage 4 cancers have metastasized to distant organs, and they are very difficult to treat or cure. Next. The diagnostic modalities. After taking medical history and physical examination, we can go for urine for urinary tumor markers. And the other modality is cystoscopy, which is invasive. We can detect growth in the bladder and determine the need for biopsy or surgery by TURBT, transurethral resection of bladder tumor. Next. TURBT, a transurethral resection of bladder tumor or transurethral resection, is used for diagnosis and staging as well as treatment. Next. Other diagnostic modalities are imaging, imaging of pelvic and abdominal region. These are renal ultrasound, IBP, retrograde pyelogram, CT scan, MRI, PET scan, or CT MRI urogram. A CT urogram is a test using a CT scan and a special dye to look at the urinary system, including detection of the bladder tumor. Next. Management and treatment. actually, this part will be discussed in detail by Dr. Rohit Swami in next session. I will give you just a brief basic idea. The surgical management, the transurethral resection of the bladder tumor, TURBT, is used most often for early stage of disease. The partial cystectomy, the removal of some part of bladder is used for a single tumor that invade the bladder wall in only one region. A radical cystectomy, the used for more extensive cancer or in advanced disease. Next. Chemotherapy. Chemotherapy may be given by two routes: intravesical chemotherapy or systemic routes. Sorry, एक मिनट. हेलो. हाँ, एक मिनट मैं अभी आधे घंटे बाद में बात करूँगा. मैं कोई एक जो मिनट में. ओके. Intravesical chemotherapy include mitomycin, C, gemcitabine, docetaxel, and valrubicin. And if you talk about systemic chemotherapy, the most common regime for systemic chemotherapy is given in the advanced stage, and it include the cisplatin, carboplatin, gemcitabine, docetaxel, paclitaxel, or pemetrexed. Next, immunotherapy. It is novel therapy, and it uses the body's natural defense to fight against the cancer. It includes BCG or interferon, and it can be given also in by systemic route. It includes atezolizumab, avelumab, nivolumab, or pembrolizumab. Next. Targeted therapy. Targeted therapy is a treatment that targets the cancer-specific genes, protein that contributes to cancer growth and survival include. And these targeted therapy include idafitinib, enfortumab, vedotin, and sacituzumab govitecan. Next. The other modalities of treatment, radiation therapy. The radiation therapy is the use of high energy X-ray to destroy cancer cells, and radiation therapy is usually not used by itself as a primary treatment, but it is typically given in combination with the systemic chemotherapy. Combined radiation therapy and chemotherapy may be used in bladder cancer that is located only in the bladder. And prognosis of bladder cancer depends on the stage at the diagnosis. The 5-year relative survival rate in the carcinoma in situ is 95.8%. And if the tumor confined to the primary site, this rate is 6.9.5. If the tumor is spread to the regional lymph nodes, the 5-year relative survival rate is 36.3, and in metastasized or distant tumor, it comes to only 4.6%. Next. Okay, this is from my side, and the advancement of treatment in the bladder cancer will be discussed by Dr. Rohit Swami in further session. And over to Dr. Rohit.
Thank you, Dr. Mukesh, for a lovely session covering all epidemiology as well as treatment part, diagnosis as well as prognosis of the bladder cancer. Now I'll go with my talk, which is recent advances in treatment of urothelial carcinoma. Is my screen visible?
Yes, visible.
So just make it full screen, sir. Yeah, perfectly fine.
Okay. Okay. So, as you all know, that bladder cancer is highly chemosensitive, radiosensitive, as well as even in the neoadjuvant as well as in the metastatic setting, there is very good response with platinum-based chemotherapy. but there is always a challenge after the first line chemotherapy. What should be the ideal way to manage? Whether we should observe and wait for the progression and go for second line chemotherapy, or should we start a maintenance therapy? So if we before 2021, we used to give first line chemotherapy 6 cycles or more than 6 cycles as per the tolerance of the patient and response, followed by observation only. Now we have various options for treatment of advanced urothelial carcinoma, and also coming to the neoadjuvant setting in the bladder cancer. So neoadjuvant chemotherapy has always been a source of attraction because it gives a survival benefit of around 6%, 10-year survival benefit of around 6%. So even 6% is not that much, and definitely each and every medical oncologist want to harness further options to give immunotherapy or chemotherapy in the neoadjuvant setting, giving much benefit to the patients. So if it comes to neoadjuvant setting, so in the muscle invasive bladder cancer, initially there was a radiation. People used to give neoadjuvant radiation till 1980, and now it's obsolete completely. And it was a neoadjuvant method at that time. In 2013, 2003, first time the chemotherapy was introduced in the neoadjuvant setting, and that was MVAC. And further, in 2005, those dense MVAC showed further survival benefit as compared to MVAC only. And Jam Carbo and Jam Cis duo also came in the part in 2005. And in 2014, there were certain molecular biomarkers which were explored, which may predict good response to neoadjuvant chemotherapy, giving overall survival benefit to patient. And neoadjuvant checkpoint inhibitors were studied since 2016, and there are several studies, though phase 2 studies, single arm studies, which have checked checkpoint inhibitors in the neoadjuvant setting, and we'll discuss about that in the further slides. So if we go for the outcomes of these small single arm trials in NACT settings, if we go with cisplatin conventional dosed as cisplatin, which is dosed as MVAC, so complete response rates, pathological complete response rate are around 38 to 40%, and as low as 26% also. But if we go with chemotherapy and immunotherapy, these are single arm trials, small single arm trials. The rate has reached up to 44%, and only immunotherapy has also shown at the complete response rate of around 46, 45% in different studies. So this is an unmet need. Neoadjuvant setting is an unmet need because as we had seen the meta-analysis of neoadjuvant chemotherapy also, only those patients had the survival benefit with neoadjuvant chemotherapy who had pathological complete response or whose stages are degraded to T1 from T2 or T3. So neoadjuvant setting is definitely attractive field in urothelial carcinoma of bladder, because getting a pathological complete response post neoadjuvant therapy is important to gain a survival benefit. So what are the various therapies at present which are approved in advanced urothelial carcinoma? So if it comes to advanced urothelial carcinoma, so we know since the 1970s till 2017, chemotherapy was the only option available with us. In the 1970s, cisplatin was introduced gradually. Combination chemotherapy was introduced in 1980, and then combination chemotherapy with gemcitabine was introduced in 2008. And now it's an immunotherapy era. So since 2017, there are several data to use immunotherapy in the metastatic settings in the first line if PDL1 is good, and pembrolizumab, atezolizumab are approved agents for first line therapy in metastatic CA bladder as per the PDL1 and CPS scores. And avelumab is now in 2021 being approved as a monotherapy, as a maintenance therapy after gemcitabine and cisplatin or gemcitabine carboplatin if there is a partial response or there is non-progressive disease. So if we, why it is necessary to give a maintenance therapy after a first line therapy? Why can't we just observe? So if we see the real world data, there are several studies which are showing that only 35 to 40% of the patient who progresses on first line therapy goes for second line therapy. These patients are attrition maybe because of disease progression, because of deteriorating PS with progressive disease, or because of unwillingness of patient to receive further treatment. So there is only 40% chance that we can deliver second line chemotherapy to the patients, and so a maintenance therapy is very much necessary, and prolonging the first PFS to as much as possible so that patient survival can be increased, or there can be overall survival benefit. So this is a need to give maintenance therapy after first line chemotherapy, so that patient, there is no attrition in the patient or less attrition in the patient population. So first line therapy, as we all know, is always platinum based, and around 50 to 70% patients which are diagnosed upfront as advanced urothelial carcinoma receives cisplatin, are cisplatin eligible, and around 30 to 50% are ineligible. And what are the ineligibility criteria we'll discuss in the next slides. So these ineligible patient, around 75% of these patients are eligible for carboplatin based therapy, and rest 25% out of these ineligible population is either suitable for immunotherapy, or they go for single agent gemcitabine or paclitaxel as per the comorbidities and patient status. And the factors which decide is the performance status and renal function, neuropathy, age, and other factors. So what are the criteria which says us that whether it is a platinum eligible or whether it is a platinum ineligible? So it is a result of a survey of 60 medical oncologists which were dealing in genitourinary carcinoma only in US. And as per their suggestions, the basic author conclusions, the basic things which says us whether the patient is platinum eligible or ineligible, is that up to PS2 it's okay, PS2 10 it's okay to go with platinum, but if it is PS3 or creatinine clearance is less than 30, or there is peripheral neuropathy which is more than grade 2 or grade 2 itself, and if there is a heart failure class of NYHA class more than 3, and if PS2 also, if creatinine clearance is less than 30, then author concludes that these patients are ineligible for platinum based therapy. And 94% of these medical oncologists said to give carboplatin followed by avelumab maintenance for cisplatin ineligible patients. And 6% of these doctors preferred carboplatin plus pembrolizumab in first line setting, and around 28% checked PDL1 status prior to starting pembrolizumab, and around 48% checked status prior to use atezolizumab. So as per the guidelines, we know that we have to check PDL1 status, CPS score before going for first line immunotherapy. But here consensus is that 94% of genitourinary medical oncologists go for platinum based therapy in the first line setting, followed by maintenance with avelumab. So what are the approvals for upfront first line PD1, PDL1 therapies? So for pembrolizumab, it is PDL1 positive with CPS score more than 10. We can go with pembrolizumab as a first line immunotherapy, and for atezolizumab, we can go with CPS score of more than 10, more than 5%. But all of these patients should be platinum ineligible to go with immunotherapy in the first line setting. So till now, what are the various approaches which we have? What are the various options which we have to maximize the overall survival of advanced urothelial carcinoma patient? So first is the wait and watch, which was till 2021. We had this option only. We used to give first line chemotherapy, then we observe till the disease progression, then we go for second line chemotherapy. Second is switch maintenance, which we have now with avelumab. We give first line chemotherapy induction followed by maintenance with immunotherapy, and on progression we go for second line therapy. And third is continuation of maintenance therapy that we give with chemotherapy and immunotherapy upfront, and then after that we maintain we go with maintenance immunotherapy, and after that we go for second line therapy. So we will discuss these three options which are available to medical oncologists in advanced urothelial carcinoma, which one is good and which one is best. So first of all, we'll go with the chemotherapy alone, wait and watch option. So if we give first line chemotherapy, where 50 to 80% of patients achieve disease control on first line platinum based therapy. However, overall survival is limited because gradually these tumor get chemo resistant and progresses on these therapy. And after giving second line therapy, median overall survival with this approach if is around 14 to 50 months if we go with cisplatin based chemotherapy, and almost similar if we go for carboplatin based chemotherapy. So median overall survival of the patient who receive first line chemotherapy observation followed by second line chemotherapy is around 14 to 15 months as per different studies. If we go with chemotherapy plus immunotherapy in the first line setting, so what are the options which are available with us? So there are three studies which has been done, and IM Vigor gave atezolizumab with chemotherapy. There was PFS benefit, but even after second interim analysis, there was no survival benefit. And atezolizumab with chemotherapy is not approved for first line setting. If we go for Keynote 361, then pembrolizumab with platinum-based chemotherapy was given. It was negative study, and there was no survival of PFS benefit. And darolutamab plus tremelimumab was also given. That was also a negative trial, Danube trial, and did not meet overall survival endpoint. So I don't think that there is any good option of giving upfront chemotherapy and immunotherapy in the first line setting, as there is no PFS or overall survival benefit in any phase 3 study till date. And if we go for switch maintenance study, so we have a very strong data of Javelin Bladder 100, which showed us that there is a significant overall survival benefit if we go with platinum-based chemotherapy followed by avelumab maintenance. So after the response from platinum-based chemotherapy, whether partial or complete, around 50 to 80% get benefited after first-line platinum-based chemotherapy. So, however, if we go for observation, these patients progresses within 9 months, and overall median overall survival is around 14 to 15 months, as we had seen. So, Javelin Bladder 100 uh, uh, study had the first line chemotherapy for fixed duration, 4 to 6 cycles, followed.
Hello? Sir, your voice is not audible, sir. We can't hear you, sir. No, sir. No. सर जस्ट एक बार आप आपका हेडफोन्स रिमूव करके फिर से करके देखिए. No, sir. नो सर एक बार विदाउट हेडफोन्स ट्राई करके देख सकते हैं क्या? We can't hear you, sir.
Hello, am I audible now?
Yes, sir.
audible.
So can I
Okay.
share your slides?
Yeah, you can share my slides. Come to slide number 17. Hello.
Okay, sir.
Okay. So shall we start?
Yes, sir.
So as we were discussing, Javelin Bladder 100 phase 3 study. So around 700 patients were randomized in 1:1 fashion in avelumab arm as well as by supportive care alone arm after first line chemotherapy. And each of these patients had received either CR, PR, or had stable disease. And these patients were further stratified according to the best response to first line induction chemotherapy and metastatic site, whether they are visceral or non-visceral. And coming to baseline characteristics, so median age was around 68 and around 75% patients were male, and all were of good PS, 0 to 1 PS, and visceral metastasis was there in 55% of patients. Next slide, please. And first line chemotherapy regimen, so most of these patients had received gemcitabine cisplatin, 52%, followed by 42% gemcitabine carboplatin, and 6% received other regimens. Next slide, please, consisting of platinum compound. So coming to overall survival, and investigator assessed progression-free survival in these uh, overall population. So more than 2 years of median overall survival and more than two times of PFS was seen in the avelumab arm as compared to best supportive care arm only. So median overall survival was around 23.8 as compared to 15 in avelumab arm versus best supportive care arm respectively. And at 2 years, median survival was around 50% in avelumab arm as compared to 38%. And similarly, at 36 months, median survival was around 36% as compared to 29.8% in best supportive care arm only. Similarly, there was significant PFS benefit, and median PFS was around 5.5 months as compared to 2 months in best supportive care alone. And if we go with the PDL1 status, next slide, please. So overall survival as well as PFS benefit was seen in PDL1 population also. Here the survival benefit was more as compared to overall population, and median survival was around 30 months as compared to 18.5 months in best supported care only. And at 2 year overall survival was 58% as compared to 42%. Similarly, there was significant PFS benefit in PDL1 population in avelumab arm as compared to best supported care alone. Median PFS was around 7.5 months as compared to 2.8 months only in best supported care arm. And coming to safety profile, next slide, please. So in the patients who are in arm of avelumab and best supportive care, around 30% patient has immunotherapy related side effects, and there was no grade 4 or fatal immune related side effect. 9% of these patients received oral prednisolone of dose equivalent to 40 milligram per day because of immune mediated adverse reaction, and around 12% discontinued avelumab because of adverse event. In common adverse event were the same as we had seen in uh, uh, previous avelumab studies, which were fatigue, pruritus, or UTI, diarrhea, arthralgia. Most of them were autoimmune related side effects. Next slide, please. So if we go with the overall survival benefit and PFS benefit as per the response with first line chemotherapy, so all the patients, whether they received complete response or partial response or had stable disease after first line chemotherapy, had survival benefit as well as PFS benefit with avelumab maintenance as compared to observation after first line chemotherapy. Next slide, please. And if we compare these patients as per the number of chemotherapy received before avelumab maintenance, then each group, whether they receive 4 cycle or 5 cycle or 6 cycle, has significant survival benefit with avelumab maintenance. whether it is a 4 cycle, 5 cycle, or 6 cycle before starting Avelumab as compared to best supportive care. Next slide, please. And if we go for overall survival benefit with Avelumab, irrespective of duration of TFI before maintenance. So even whether it was starting of maintenance Avelumab and between 4 to 6 weeks after chemotherapy, or 6 to 8, or more than 8 weeks, 8 to 10 weeks, there was significant survival benefit in all of these three subgroups. And Avelumab gave survival benefit even if you start it after 4 weeks of chemotherapy, or as late as after 10 weeks of chemotherapy. Next slide, please. So Asian subgroup analysis was also done in ESCO 2022 to see whether this overall survival benefit is maintained in Asian subgroup also. Next slide, please. So 21% of Asian population, 21% of study population were of Asians, and subgroup analysis in this study population also had the similar design of randomization with Avelumab and best supportive care after partial response, complete response or stable disease, with the same primary endpoints of survival benefit and PFS analysis in all randomized patient as well as PD-1 patient, and were stratified as per the best response to first line induction therapy as well as metastatic site, whether visceral or non-visceral. Next slide, please. And baseline characteristics were well balanced in both arms in Asian population also, as well as in the PDL1 population in the Asian population group. So around 147 were Asians, and around 71 were PDL1 positive in this study. And baseline characteristics were comparable in both the arms. Next, please. And even in Asian population, we can see the curves. There was a significant overall survival benefit with Avelumab maintenance after first-line chemotherapy, and median survival was around 25 months as compared to 18 months with best supportive care only. Even in PDL1 positive population also, there was significant survival benefit in Avelumab, which was 26, median survival was 26 months as compared to 19 months in best supportive care only. So side effects in the Asian population were also similar as per the next slide, please. As per the overall population, and similar side effect profile was there. Though there was one death in Avelumab as well as in the best supportive care because of COPD in best supportive care, and because of sepsis in Avelumab arm. And immune-related side effects were also around 27% in Asian population, which was similar as compared to the whole population of this study. Next slide, please. So coming to the guidelines, what the guidelines says us at present about first line, second line, or maintenance therapy in metastatic bladder cancer. Next slide, please. So for the cisplatin eligible NCCN, ESMO, as well as EAU guidelines says us to go with the platinum based therapy. Combination therapy is preferred as compared to single agent cisplatin, whether to go with gemcitabine cisplatin or go with dose dense MVAC, and followed by maintenance Avelumab therapy. Maintenance Avelumab therapy is in the guidelines, endorsed in guidelines of NCCN, ESMO, as well as EAU. And for cisplatin ineligible, there are other options to give. First and preferred option will be gemcitabine maintenance. Am I audible?
Yes, Dr. Rohit, audible.
Yeah, so maybe some network glitch. So for cisplatin ineligible, we can go with gem carbo followed by Avelumab maintenance, which is category 2A, and we can also go with atezolizumab or pembrolizumab as per the PDL1 status and as per CPS score. And for the second line, we can go with the second line chemotherapy or the targeted agent. If EGFR negative, then we can go if FGFR fibrogen growth factor receptor negative, then we can go for enfortumab or sacituzumab, and if it is FGFR is positive, we can go with erdafitinib, but only after progression on chemotherapy as well as after progression from immunotherapy. So, coming to Javelin Bladder 100 trial summary of the patients who progressed after the avelumab. So, around 43 patients are still out of 700. Around 43 patients are still on. Next slide, please. Are still on avelumab and best supportive care, whereas 307 are discontinued. And out of these 307, significant number, that is 122, are not on any second line treatment. And the patients 185 who are receiving second line treatment, most of them are on platinum based chemotherapy only, re-challenged with platinum based chemotherapy or other anti-cancer agents, non-platinum based therapies, and around 11 only are on immunotherapies at present. Next slide, please. So if we go with overall survival in avelumab, as per the second line treatment, so there is no survival difference whether we give chemotherapy or immunotherapy or other platinum based therapy in second line setting. And though we can definitely see there is a good response rate with chemotherapy in second line setting if we re-challenge with second line platinum based chemotherapy. Next slide, please. And coming to the phase 3 study, which is a new option available to us if a patient is FGFR negative and the patient is progressed on platinum based chemotherapy. So we have now option of enfortumab vedotin, which is a chemotherapy conjugated antibody. And this phase 3 study showed that there is a survival benefit as compared to chemotherapy in the second line setting post progression on the first line chemotherapy, cisplatin based chemotherapy. And these second line chemotherapies, as per the treating physician's choice, and there was survival benefit in using enfortumab post first line progression on first line chemotherapy with cisplatin. So median PFS was around 5.5 months as compared to 3.7 months in second line chemotherapy setting, and overall response rate was also good with enfortumab, which was around 41% as compared to 18%. And disease control rate was also significant with 71 months as compared to 53 months with second line chemotherapy. Though side effect profile was definitely in favor of chemotherapy, though almost all the, if we go with overall adverse event rates, though it was similar in both chemotherapy as well as enfortumab vedotin arm, and serious side effects are also well matched in both the arms. So enfortumab vedotin is also option available to us after progression on first line platinum based chemotherapy. And next slide, please. And then there is a phase 2 study of erdafitinib, which has shown us PFS as well as survival benefit. Next slide, please. Which has shown at PFS as well as overall survival benefit. It was a single arm study. So there was PFS median PFS of around 5.5 months after the progression on second or third line prior lines. And if we go with the prior immunotherapy, around 5, if we go with first or second or third line prior lines of chemotherapy, then PFS was around 5 months or 5.7 months. Even if patient has received prior immunotherapy, then still PFS was around 5.7 months. So it is also option available to us, erdafitinib, especially in FGFR positive urothelial carcinoma. If there is progression on chemotherapy followed by immunotherapy, we can challenge the patient with erdafitinib, which can be our preferred third line. Next slide, please. And then upfront to pembrolizumab in keynote 45. So this was a phase 3 study, which compared pembrolizumab with the chemotherapy, which was paclitaxel, docetaxel, and benflunin in the patients who had transitional urothelial carcinoma of pelvis, ureter, or bladder, and had previous first or second line of platinum-based chemotherapy has progressed within 12 months after a definitive treatment with platinum-based therapy. So it was a second line setting, and second line immunotherapy was compared with the second line chemotherapy, and there was significant survival benefit in the pembrolizumab arm, and best response and best PFS benefit was seen in the patient who had PDL1 positive disease and whose CPS score was 10 or more than 10. Next slide, please. So, how to maximize benefit from first line therapy for this to get the maximum median overall survival with different strategies, as we had already discussed. We can go with the platinum based treatment followed by maintenance immunotherapy, where we have the option of Elumab, which is the best way to go. We can go with chemotherapy with immunotherapy maintenance. Sorry for discontinuation. So, among all of these three studies, as we have seen, the Evolumab has shown us highest survival benefit among all the three studies. And if we go with chemotherapy followed by Evolumab maintenance, we have the best median overall survival for around 30 months as compared to 16 to 18 months or 12 months, as with the different strategies of giving chemotherapy and observation followed by second line chemotherapy, or giving chemotherapy in combination with immunotherapy followed by immunotherapy maintenance. Next slide, please. So coming to conclusion, as we had seen the long-term follow-up from Javelin Bladder 100 trial, we had seen that there is a significant survival benefit and PFS benefit if we go with Evolumab maintenance as compared to best supportive care after first-line chemotherapy after achieving good response as a partial or complete response, or if still we have stable disease, we can go with Evolumab maintenance with good survival benefit. Median overall survival was around 23 months as compared to 15 months only in best supportive care arm, and overall survival rate at 2 years was 50% Evolumab as compared to 38% in best supportive care, and overall survival was prolonged with Evolumab maintenance despite high proportion of patient treated with best supportive care alone receiving the subsequent second line of therapy. And safety tolerability wise, only 19% of the patient had discontinuation of Evolumab because of adverse events. So, concluding that the standard of care at present is to give first line chemotherapy with platinum based doublet with the gemcitabine cisplatin or gemcitabine carboplatin followed by maintenance Evolumab after 4 to 6 cycles. So this is the best approach to go with in the first line setting with metastatic urothelial carcinoma of urinary bladder. Thank you everyone.
Thank you, Dr. Rohit. It was very excellent or very tremendous session, and you have covered all aspects of immunotherapy and chemotherapy on the basis of recent trials or guidelines. Thank you, Dr. Rohit.
Thank you everyone for patiently listening and joining our this interactive session. So should we conclude study? Should we conclude this webinar?
Yes, sir. Yes, sir. Thank you so much, sir.
Okay. Thank you.
Good night, sir.
Thank you. Good night.
Good night, sir. Support team, we can close the meeting.